Good morning, everyone, and I would like to thank Dr. Veena for the invite. It's lovely being here. It's a very serene, beautiful campus. Uh, just following up from what Akhila spoke, I think glass prescription in children is very difficult. And she said it's an art rather than a science. Now, moving on from glasses, let's look at what the next pandemic, if we can speak of myopia. Let's look at what the recent developments have been in myopia. I'll cover myopia and its burden briefly, the risk factors for progression, and then we'll have a look at few of the recent advances in myopia management, whether it's pharmacologic, optical, or light therapy. We heard this morning from Dr. Venkatesh sir also about how myopia is increasing. The prevalence has increased. We still don't know the cause. Why are we seeing this increased prevalence? We know it's multifactorial. Billions of dollars have been spent on research. And one of the reasons is because one of the dreaded complications, though rare, is vision loss. So just coming back to the risk factors, I spoke about the parental myopia being a risk, near work, peripheral hyperopic defocus, and light exposure. The strongest factor probably tends to be the near work. With increased amount of near work for children these days with homework and academic activities, this could probably be one of the risk factors. Now, what are the tools we have to combat myopia? I like to call these as the myopia control army. I think the first and the most important tool is to ensure that we fully correct them. There is absolutely no role of undercorrection in myopia. Soft contact lenses, probably the multifocal soft contact lenses have a role. Orthokeratology has a role. It is temporary, probably not. It is very effective, but temporary. Atropine, we know through studies is that it's probably one of the highest effective forms of treatment of myopia progression. And recently, there has been an interest in red and violet light therapy. What does WSPO say? The latest guidelines say that if you look at myopia control as a pyramid, then the base of the pyramid actually is lifestyle modifications, ensuring that children get adequate outdoor exposure, they sleep well, they don't look at gadgets too much. That is probably the base of the pyramid for myopia control. And then you top it up with the next-gen glasses, contact lenses, if needed, ortho K. And the peak or the apex of the pyramid is low-dose atropine. There's no role for undercorrection. Progressives and bifocals probably very, very limited role, and blue light blocking lenses and RGPs probably even more so. Atropine is our best friend, and though it's our best friend, probably till date, we don't really know how it works in myopia. We hypothesize that probably it acts on the parasympathetic muscarinic receptors, causing a little bit of mydriasis and cycloplegia. I'm talking of low dose atropine, and it also tends to decrease the rate of growth of the sclera, thereby reducing axial length elongation. And interestingly, whatever minimal pupillary dilatation it does tends to expose us to a broader range of ultraviolet spectrum, thereby reducing inflammation and scleral growth. Whatever we know about atropine today is thanks to ATOM. So it's actually the ATOM studies that we owe a lot to. We know about the ATOM studies, but to just summarize, ATOM 1, what did they do? They looked at 1% atropine. They administered atropine in 400 children between 6 to 12 years of age with -1 to -6 diopters of myopia. And the conclusion was that although it was effective in decreasing the spherical equivalent progression as well as axial length elongation, after a washout period, there was a large rebound noted. Then they went on to conduct their ATOM 2, which was to look at lower doses of atropine, so 0.01, 0.1, and 0.5%. And the 0.01% group actually was most efficacious. Following the ATOM study, what we also got to hear from the LAMP study, or the low concentration atropine for myopia study, this was a RCT, it was a placebo-controlled trial done from Hong Kong, which looked at further lower doses. So this looked at 0.05% and 0.025% along with the 0.01% topical atropine. And in this, it was the 0.05% group, which was highly efficacious. So we have two doses of atropine thanks to research, the 0.01 and the 0.05% group, which we know is effective. We have an in-house study as well. This is the IATOM or the India ATOM study, which is again confirmed that the 0.01% atropine works very well. So from all these studies, we know that atropine, which is it's just an eye drop, is very efficacious in controlling myopia progression. So having looked at the pharmacologic interventions, let's go into the optical part. Now, we know that one of the traditional cues for axial elongation is this peripheral hyperopic defocus. So most of the optical interventions are done to target this peripheral hyperopic defocus by creating a myopic defocus in the periphery. One of the earliest glasses was the Myovision by Zeiss. It had a central distance zone with a peripheral addition. It is not very popularly used, though probably used in Canada and some of the European countries. And long-term studies have not shown it to be as effective as some of the newer generation glasses. In the newer generation glasses, we have the Myosmart by Hoya. Now, this works on the principle of the defocus incorporated multiple segments. So what these are basically is there is a central optical zone of 9 millimeters surrounded by a 33 mm rim of peripheral hyperopic lenslets. So each lenslet is about plus 3.5 diopters. What does it do? It targets the peripheral hyperopic defocus. Very effective. Studies have shown that it slows down up to about 0.52 diopters at the end of 3 years. Good adaptation as well. Children have accepted these glasses quite well. Along similar lines, we have the Stellest by Essilor. This works on something called highly aspherical lenslet target, or the HALT technology. This has concentric rings. So if the DIMS glass had a peripheral rim of lenslets, this actually has concentric rings, which creates something called a VOMD, or a volume of myopic defocus. So the zone that it targets compared to DIMS is slightly larger. Along similar lines is the Myocare by the Zeiss group. Now, how do these glasses perform? DIMS probably is the only one for which we have 6-year data, and 6-year data has shown that it is effective in reducing axial elongation as well as progression of the spherical equivalent. Now, where do these spectacle designs stand with respect to each other? So I didn't cover one aspect, that is the DOT, or the diffusion optic technology. The first part in this, the diffusion optic technology basically has small dots away from the center. The center corrects the refractive error, whereas in the periphery, there are small dots. And what these dots do is they reduce the contrast vision to the periphery of the retina, with the belief that once you reduce contrast, it prevents myopia from progressing. So it's a different principle to DIMS and HALT, or the DIMS glasses, but the similar end result. How do these do when compared to each other? So if you look, probably at this point of time, it is safe to say that it's the DIMS and the HALT technology that seems to be more efficacious than the other two. So having spoken about the pharmacologic interventions and the glasses, let's move on to the soft contact lenses. These are multifocal soft contact lenses. So similar to what we spoke about the glasses. The glasses, what do? They correct the peripheral hyperopic defocus. Contact lenses essentially are doing the same thing. So there's a central zone which corrects the refractive error with a peripheral add. Right now, the FDA-approved contact lenses are the MiSight lenses from Cooper Vision and the NatureView lenses, which are extended depth of focus lenses. The MiSight lenses, again, RCTs have shown that these are effective. Almost, they reduce not only the spherical equivalent, but also the axial length. These are the NatureView lenses by Visioneering Technologies, which are extended depth of focus lenses, again, which have been tried in myopia control. What does research tell us? Now, if you look at the study, the Blink study, this compared single vision lenses with multifocal lenses. And in the multifocal lenses, they had two groups. They had one with a plus 2.5 diopter add and one with a plus 1.5 diopter add. And you can see that it is the one with the plus 2.5 diopter add which had the slowest progression in myopia. So multifocal contact lenses do work. The only issue with these lenses is the pricing and the availability. Everybody's favorite, orthokeratology. I call this everybody's favorite because I think almost all of us would have had patients coming to us who have either questions about ortho-K or who are on ortho-K as soon as the diagnosis of myopia has been made. So these are reverse geometry lenses which are worn overnight. They flatten the cornea when worn overnight, and it reduces the peripheral hyperopic defocus. And this provides clear daytime vision along with myopia control. How effective are these? Compared to standard contact lenses, these are effective, but the only issue with ortho-K lenses is in children, there is a slightly higher risk of keratitis with ortho-K lenses. This is the last slide. This is about the low level red light therapy. This is something that's new and recently being studied. Although the exact mechanism is not known, it is felt that it probably works at a cellular or a neuronal level. Studies have shown changes in axial length and spherical equivalent changes. The studies claim that these are almost as effective as atropine or the hyperopic or the glasses, the new generation glasses. But just to bear in mind, if you read between the lines, the follow-up period is about 8 months to 12 months at best for these light therapies, unlike the atropine and the glasses, which have which have longer follow-ups. So I would like to conclude by saying that to deal with myopia, we have multiple arrows in our quiver. We are no longer helpless. We should actually feel helpful. I think as ophthalmologists, it's very important that we take away the fear from the minds of parents, because when you're dealing with a child with myopia, it takes more time to talk to the parent than to do a refraction and write the glass prescription. And I think in these times where technology is advancing and we are learning all these newer concepts, it's very exciting to be a pediatric ophthalmologist. Thank you all for your patient listening, and thank you for the opportunity.